Welcome. The following presentation from Answers in CME is part of an educational activity titled Guidance on Menopause-Related Vasomotor Symptom Management, a focus on neurokinin-targeted treatment options. To access the full program and supporting materials and to claim your certificate, please visit the activity URL in the episode description. This activity is supported by an educational grant from Bayer Healthcare Pharmaceuticals Incorporated.
I'm Dr. Denise Black. I'm an assistant professor in the Department of Obstetrics, Gynecology, and Reproductive Sciences at the University of Manitoba in Winnipeg, Manitoba, Canada.
Hi, I'm Dr. Jill Liss. I'm a board-certified OBGYN at the University of Colorado in Denver.
Thanks for joining our program on management of vasomotor symptoms of menopause. Menopause is a significant event in the life of a woman. Menopause is defined as 12 months of consecutive amenorrhea. Perimenopause is the time leading up to that. The average age of menopause is 52, with normal being age 45 to 55. Some women will go through menopause earlier. Vasomotor symptoms are common and can be disruptive for years. Vasomotor symptoms during menopause are a common challenge. During the menopause transition, 80% of women will experience hot flushes. They can be moderate to severe. They persist and last 7 to 10 years. Many women will be quite symptomatic, experiencing more than 10 vasomotor symptoms per day. And those with more severe vasomotor symptoms are at higher risk of sleep disruption, cognitive function impairment, as well as depression, anxiety, and other quality of life concerns. Sleep disruption during menopause is common. Data from the SWAN trial show that about 50% of women will report sleep disruptions during the menopause transition. The most commonly reported sleep disruption is that of waking up several times during the night. When you have sleep disruptions, there is reduced quality of life and decreased work productivity. So, Dr. Liss, in your experience, how significantly do vasomotor symptoms impact the quality of life and overall functioning in some of the people that you treat during menopause?
Vasomotor symptoms can really have a huge range. For some people, they're a minor nuisance, but for other people, they're completely life-altering. I have patients who have left the workplace, who have had strained relationships, have significant sleep and stress disruption. And so I think it's really important to talk to the patient about the degree of severity and how much it's impacting other aspects of their life. And when it is severe, it can be extremely profound. During the menopause transition, there's a lot of changes related to both chronologic aging and ovarian aging, or the menopause transition itself. Many of these things are also overlapping. So it's an inflection point for many other cardiometabolic health problems, including cholesterol, like lipids, lower HDL function. There also may be increased risk of diabetes and metabolic syndrome, sleep apnea. Mood symptoms may pivot during this time. That may be a transient period of worse mood symptoms, but there's also chronologic aging happening, things related to weight gain, loss of lean muscle mass, and decreased energy expenditure. It's really important that we take a thorough and holistic view of what's going on for a patient during the menopause transition to address both overall health as well as symptoms potentially related to the menopause transition itself. Now, let's hear from a patient who struggled with her menopause symptoms for years before getting treatment.
Hi, I'm Danielle. I am a 44-year-old mother of 4 boys, and I first started experiencing menopause symptoms about 3 years ago. I had unexplained weight gain, fatigue, my skin felt really dry. I had a lot of loss of focus, but one of the biggest issues was hot flashes and night sweats. I had them all the time. They kept me from sleeping well. I was changing my sheets and my pajamas multiple times a night, and it really, really had an effect on my entire day and who I was becoming. One of the biggest ways that I was impacted by the symptoms was not being able to focus at work, because I wasn't getting any sleep. And I was really short with my kids and my family. I felt like I had a really, really short fuse and like I just couldn't handle all the normal things that I used to be able to handle. The symptoms start like kind of slowly, and then it's not until you're completely bogged down by them that you seek help. I felt like I was falling apart.
Thanks, Danielle. In the next session, we'll discuss how to identify and assess vasomotor symptoms in your patients.
In this next session, we'll talk about assessing symptoms of menopause and determining when treatment is warranted. So, helping patients to identify that vasomotor symptoms are not just a normal part of aging is an important part of what we do. Vasomotor symptoms are generally an affirmative diagnosis. Very infrequently do I have people say, "Oh, is this a hot flash?" When it's a hot flash, people generally know it, and it's generally characterized by perspiration, flushing, chills, clamminess, anxiety, etc., and can be described as mild, moderate, or severe. And there are specific definitions that the FDA has put together for criteria for clinical trials, but it is very much a subjective assessment. If someone is telling me they are having severe hot flushing, I don't need to go through all of the parameters. If it is severe to the patient, this is a severe hot flash. There is some variation in vasomotor symptoms experienced by patient subgroups. Black women may have vasomotor symptoms that are earlier and last longer. Obese women, smokers may experience worse vasomotor symptoms. People on some medical therapies, especially endocrine therapies for cancer treatment, may have worse vasomotor symptoms, and transgender people may experience vasomotor symptoms as well. So, Dr. Liss, how can we distinguish menopause-associated vasomotor symptoms from hot flushes that may be due to other conditions?
I think most of it comes down to taking a good history and the story fitting. So if somebody's over age 45, it's happening in a progressive sequence that would make sense with the menopause transition. It's almost always going to be menopause-associated vasomotor symptoms. When they're happening remote from menopause, or if you've trialed therapies like hormone therapy and they're not resolving, those are scenarios where I'd want to take a closer look and do a more exhaustive workup. Let's discuss when patients should be treated for VMS. This comes from guidelines from several large organizations, including ACOG, the Menopause Society, Canadian Menopause Society, and the endocrine societies. The bottom line is that believe the patient when they tell you they have bothersome VMS and treat them. Let's hear from Danielle again.
I first went to see my PCP about my perimenopause symptoms about 3 years ago, and she told me that my labs were normal, that it was a normal part of aging, and that there was no real testing that they can do, that I should just eat more fruits and vegetables, try to work out a little more, and get better sleep. So I took those things to heart, and I did do them. And then a year later, I went back with no changes in those symptoms. I saw a different provider because mine was on maternity leave. I went over my symptoms again. I spoke about how they had not improved, and this different provider just reiterated what I had heard before: eat better, sleep more, lose weight. And then when I returned back to my doctor for an unrelated pre-op appointment and asked again and was again dismissed, I began to think that it was possibly something in my head and it was mental and not physical, and actually sought out a psychiatrist to help with my symptoms.
Thanks for sharing, Danielle. Next, let's review recommended treatment options for managing VMS. In this session, let's review what pharmacologic options we have available for treating vasomotor symptoms. Hormone therapy is considered the first-line treatment for treating most patients with vasomotor symptoms. They are extremely effective and typically effective around 1 month after initiation. This typically involves a combination of estrogen alone in those who do not have a uterus, or plus a progestogen in those that do have a uterus. In the non-hormone category, there are 2 FDA-approved NK receptor targeted therapies, elinzanetant and fezolinetant, and other non-hormonal therapies that are typically off-label: SSRIs, SNRIs, gabapentin, and oxybutynin. Most patients, about 90%, will be candidates for hormone therapy, but this discussion is important. It's important to take a good history and employ shared decision-making when arriving at that decision. Generally speaking, younger women less than 60 or less than 10 years from menopause onset are good candidates. We want to make sure there are no contraindications. And the best candidates are those who have bothersome VMS, have concerns for osteoporosis or have osteopenia, and have a personal preference to use hormone therapy. When assessing the appropriateness of a candidate for hormone therapy, it's important to think through the contraindications. And of note, there are several contraindications to oral contraceptives that are no longer a contraindication to hormone therapy. Hormone therapy contraindications include unexplained vaginal bleeding, prior estrogen-sensitive breast cancers, severe active liver disease, history of heart disease, stroke, or heart attack, as well as caution around people with a history of an inherited high-risk thrombophilia. Things that are importantly not on this list are controlled hypertension, history of migraine with aura, and a high-risk familial gene or predisposition for breast cancers. Dr. Black, when a patient is unwilling or unable to take hormonal therapy, how do you choose between non-hormonal options?
Well, that's a great question. Up until a few years ago, if a patient had a contraindication or a desire to avoid hormone therapy, I didn't really have a whole lot of options that were approved for this indication or that worked terribly well. With the advent of some of the newer medications, we can now offer people therapies that work quite well and have a favorable side effect profile. When looking at the options for non-hormonal therapy for vasomotor symptoms, on-label approved for the indication of vasomotor symptoms include paroxetine salts in the US and both fezolinetant and elinzanetant. These medications are effective for hot flushes. They may also have some benefit for things like sleep disturbances and in some instances mood issues. Gabapentin is off-label for vasomotor symptoms, but can help hot flushes somewhat as well as sleep disturbances. SSRIs or other SNRIs are again off-label, provide some benefit for hot flashes, but may provide some improvement in mood. And oxybutynin is off-label, but does have some benefit for hot flushes. So we have many different preparations, some just for hot flushes, some that have other benefits with varying side effect profiles and degrees of efficacy. So in the next session, we're going to look a little more closely at the newest drug class for vasomotor symptoms, the neurokinin receptor-targeted therapies. In this session, we're going to learn more about the use of elinzanetant and fezolinetant for the management of vasomotor symptoms. So now approved worldwide are two neurokinin receptor-targeted therapies. Fezolinetant is approved in US, Canada, the UK, EU, and others. Its indication is the treatment of moderate to severe vasomotor symptoms associated with menopause. It is a selective neurokinin 3 receptor antagonist. Elinzanetant, approved in the US, Canada, UK, EU, and others, has the indication of treatment of moderate to severe vasomotor symptoms associated with menopause, and in the European Union also has the indication for vasomotor symptoms caused by endocrine therapy for breast cancer. It is a dual neurokinin 1 and neurokinin 3 receptor antagonist.
Decreasing estrogen in the menopause transition leads to loss of negative feedback at the level of the KNDy neurons, which are neurons that live in the hypothalamus at the thermoregulatory zone. This results in hypertrophy and increased activity of the KNDy neurons, leading to destabilization of the thermoregulatory system and increased frequency and severity of vasomotor symptoms. KNDy neurons express a neurokinin B receptor called NK3R. Fezolinetant and elinzanetant act on this receptor as an antagonist, which in turn quiets the trigger for the vasomotor symptoms. Dr. Black, can you talk to what effect the NK1 binding is thought to have in elinzanetant?
So the neurokinin 1 receptor is felt to be implicated or important for sleep. When the neurokinin 1 receptor is stimulated, sleep generally suffers. When the neurokinin 1 receptor is antagonized or blocked, clinical studies have shown an improvement in sleep. Next, we'll look at the data supporting this new class of drugs for treating vasomotor symptoms. In this session, we'll review the clinical data on elinzanetant and fezolinetant. For elinzanetant, the clinical trial program was called OASIS, and there were 3 OASIS trials that spoke to safety and efficacy of elinzanetant. OASIS 1 and 2 were clinical trials that had a placebo-controlled arm for the first 12 weeks, and then a crossover so that everybody received active medication for the next 14 weeks, so 26 weeks of data on each of those trials. The OASIS 3 trial was a 52-week trial. The outcomes were looking at efficacy, but this was a longer trial to assess safety. The Skylight trials were the trials that supported fezolinetant. There were 3 Skylight trials, Skylight 1 and 2, which were 12-week placebo-controlled trials looking at efficacy for hot flushes. There was then a 40-week extension, so a total of 52 weeks of data. At the end of 12 weeks, the placebo groups then went on to receive active product. Skylight 4 was the safety and tolerability trial, where there was a placebo arm for 52 weeks as well as a treatment arm. In the elinzanetant and fezolinetant studies, sleep was also evaluated. They used sleep questionnaires to help assess sleep. In the elinzanetant OASIS trials, the improvements were statistically significant. And it's interesting because the improvement that was seen in sleep was not solely due to the reduction of vasomotor symptoms, suggesting that there may be other mechanisms which are still being explored. There is ongoing study through the Nirvana pilot trial focusing primarily on the impact of elinzanetant on sleep measures. In the OASIS 4 trial, which was a unique trial involving women being treated for breast cancer with adjuvant endocrine therapy, sleep was shown to be improved in that study. So, Dr. Liss, have you had patients on this new class of therapies? In the real world, what kind of experiences are people bringing back to you?
I've seen a lot of success using these medications. Generally speaking, people are reporting significant reduction in bothersome VMS. And they're also telling me they're sleeping better. And that's likely due to both reduction in VMS, but potentially some of the other mechanisms we've discussed. I think the thing that surprised me the most in the real world is how quickly they see improvement in symptoms, sometimes within even just a few days.
That is a real game changer.
So we've heard about efficacy. The good news is these trials also showed us good safety for both of these drugs. We didn't see significant amounts of serious adverse events, and the most common side effects in prescribing might be headache or UTI, though these occur at low rates. Similarly, with fezolinetant, there were not significant adverse events. However, we did see liver test elevations, and this has led to recommendations for liver testing before and during initiation of fezolinetant. In the next session, let's review considerations for matching patients to treatment. In this session, we'll discuss how to choose treatment for those experiencing vasomotor symptoms. In general, if someone does not have contraindications to hormone therapy, we want to start with hormone therapy. Generally speaking, it's cost-effective and also highly effective at treating symptoms. These are going to include regimens of estrogen plus or minus a progestogen, depending on the presence of a uterus, as well as non-hormonal therapies, including paroxetine in the US, elinzanetant, and fezolinetant. There are off-label non-hormone therapies as well. If there are contraindications or the preference not to use hormone therapy, we have the approved non-hormone therapies as well as the off-label non-hormone therapies. When we're discussing therapies with patients, it's really important to employ a shared decision-making model. So you want to ask your patients about their menopause symptoms. Don't assume that they connect all of the symptoms of menopause, particularly mood or sleep, with the menopause transition itself. Normalize them, ask open-ended questions, talk to them about the strengths and weaknesses of various types of treatments, including hormonal and non-hormonal. I think it's important to clarify the safety of hormone therapy. So sometimes a preference not to use hormone therapy just requires some basic education and reorientation.
I think it's also important to include a discussion of the expectations. So let people know, when will you start to notice a difference? To set the bar at a spot where people do not expect 100% resolution of all of their symptoms all the time. I think it's also important that we set follow-up visits so that we give ourselves as providers the option to say, you know what, this isn't working as well as we'd hoped. Is there something else that we can modify? Because we don't necessarily always get it right the first time. So let's hear again from Danielle one more time.
After reaching out to a psychiatrist and realizing that these physical symptoms that I was having were in no way related to my mental health, I really started to research and try to find a provider that was well versed and experienced specifically in perimenopause. I was able to find a telehealth provider who specialized in later in life women's care. After that initial visit with the telehealth provider talking about my perimenopause symptoms, she prescribed treatment that was incredibly helpful within the first couple of weeks. My brain fog lifted. I started to have a little bit more energy, feel a little bit more focused. I was in no way as quick-tempered with my children. I was able to really buckle down at work and make decisions. And one of the biggest things was the hot flashes. Those were almost completely gone within a couple of weeks. And the night sweats too. It's extremely rare that I have them anymore. We've adjusted the treatment a couple of times, finding the exact right protocol for me. And I finally feel like myself. One of the things that I've learned in this journey is that it's much more commonplace in primary care and with physicians to really brush off symptoms of midlife and older women. And the truth is, there is help, there is treatment. There's no reason to feel this way just because you're a woman getting older. There is relief. And if more doctors were able to listen and help prescribe treatment, then I think a lot of women would be in a much better place after the age of 40.
Let's wrap up with a review of best practices for patient monitoring during menopause treatments. Dr. Black, do you recommend any type of blood work before starting a patient on pharmacotherapy for menopause symptoms?
Technically, blood work is not necessary before starting menopause hormone therapy. It may be necessary before starting some of the other options. Certainly, things like hormone testing are not indicated in most people, and we don't use hormone values to gauge how much product we should be giving people or whether they're on the right dosage. Before starting any sort of therapy, it would be nice to know some basic information about the patient's background cardiometabolic risk. So with that in mind, having access to some lipids might be important, as that might help you to determine, especially with triglycerides, whether or not you choose an oral or a transdermal therapy. After people start therapies, there are some specific therapies where monitoring of blood work is recommended. For those who are taking fezolinetant, because of some liver enzyme elevation seen in the clinical trials, liver function monitoring has been required. The liver function monitoring should be done prior to starting the therapy at months 1, 2, and 3, as well as month 6 and month 9. There are well set out stipulations for when treatment should be discontinued and instances when more liver function testing should be done. In the US, it is recommended but not required that those on elinzanetant have liver monitoring done at 0 and 3 months. In Canada, there is no requirement for liver function monitoring for those on elinzanetant. Now, vasomotor symptoms can last 7 to 10 years. So many of the treatments that people are on may be long-term in nature. So it's important to follow up with your patients, make sure that their symptoms are improving, ask them about adverse events, titrate their treatment, change, add additional things, anything that you need to do as needed. At some point, it's going to be appropriate to discuss when do you stop therapy. So, Dr. Liss, some clinicians recommend staying on hormone therapy for life. What is your personal perspective on that?
I don't think that all patients should be on it for life, but that's not to say that some patients shouldn't be. In general, you want to be reevaluating the risk-benefit ratio. What about you?
So I think that this is an evolving area of medicine. I remember the days when people stayed on hormone therapy their entire life. And also, I remember the days when nobody went on hormone therapy no matter what. I think it's also really important to call out some of the misinformation that is being presented in online forums and other presentations. We don't have a whole lot of data that suggests long-term hormone therapy is advantageous for overall health and wellness. So there may be people in whom long-term therapy is a good idea, something they desire, but I think that this is one of these points where, as we get more information, we're going to be able to help people make better choices. So, Dr. Liss, as we wrap this up, do you have any final thoughts or pearls about how we can provide better care to midlife patients suffering with menopausal symptoms?
Yeah, I think it's all of our responsibility. OBGYNs, primary care providers, all of us need to be taking vasomotor symptoms and menopause symptoms very seriously. We have historically minimized them, patients minimize them, but I think we need to change the culture and the tone around how we discuss them and really make sure we're asking the right questions and explaining the justifications for treating them so that patients don't needlessly suffer. How about you?
One of the legacies of the WHI is that we have had a whole generation of care providers who have not had sufficient access and training and experience with treating menopause. The end result of that is that because care providers may not know what to do, they don't bring it up with patients. They don't validate their concerns and say, yes, I know exactly what to do for you. Let's get started. So I'm really grateful for the opportunity of a forum like this to help educate people and to provide tools in their toolbox. Thank you, Dr. Liss, for an interesting discussion, and thanks to all of you for joining us today. And I hope that this gives you confidence in prescribing treatment for your patients.
Thanks so much.
Thank you for listening. Please visit the activity URL in the episode description to view all program materials, complete the post-test, and get a certificate.